Gloria is going to talk to us about the outcome and cost effectiveness data supporting antimicrobial TDM. Dr. Gloria Wong is a general and acute medicine trainee at the ICU at Royal Brisbane Women's Hospital, and she's currently doing her PhD where she's interested in the clinical use of antimicrobial TDM. So we'll just do...
I've set on the desktop. Yeah, it is good. Okay. There you go. All right. Thank you very much. So thanks for asking me to do this talk. I was asked to talk about outcome and cost effectiveness data supporting antimicrobial TDM. For those who know me, my research area is mostly in beta-lactams, but I'll cover the other groups of antimicrobials as well, make it more broad. So you probably remember seeing the slides from the morning talk from Jason, reminding us why are we doing TDMs. That's what we deal with in real life, especially for me as a clinician. That's what the chaos we're dealing with, not just in critical illness, but in other special populations of patients, that there are multiple factors that can affect our drug concentrations. Some go up, some go down, and eventually we're not entirely sure where we're going. And adding into the mix that sometimes we're dealing with, especially resistant bug, that the environment is different from the usual general populations. And from getting to this chaotic point A, we somehow know there is some significant cutoff, PKPD cutoff that is associated with either clinical or microbial positive outcome that we need to reach to. So by getting us from point A to point B, there are quite a number of methods we can do. One of the two in our toolbox is TDM. And sometimes we need to use, all of the above, some of the above in combinations to reach our targets. So TDM is a pretty long history, actually. I look at one of these papers that's celebrating 40 years of JAC, and they talk about the history of TDM and how much we can have come along and how much we still need to do. The class that we're more familiar with are the aminoglycosides and the glycopeptides TDMs. But nowadays, more emerging data are starting to come out for other groups of antimicrobial, including, for us, for our groups, we do a lot of work for beta-lactams. And indeed, quite a lot of people are doing TDMs. In this paper in 2015, it surveyed one of ICU specialists and clinicians. Majority of them do aminoglycosides, 80%, and followed by Vancomycin TDM, which most of the data are available, and emerging number of them are doing beta-lactam TDMs. And I'm sure that this will change over the next few years when we have more information and clinical data that's supporting the application of this. And what does the guideline say? This is a positional paper come out a couple of years ago from the IDSA. They specifically asked in hospitalized patients with intravenous antibiotics. There's a dedicated PK monitoring and adjustment program to improve clinical outcomes and reduce costs. And the answer is they strongly recommend doing that for aminoglycosides. And they suggest that to be done for vancomycin. And we're going to look into some data that support these kind of recommendations. So the first one is the one that we're more familiar with is aminoglycosides. This is quite an old paper, old data, but I think that we can't quite really get away from not talking about this when we talk about clinical outcome and the cost effectiveness in terms of aminoglycoside TDM was quite a major study. So this is done in 1999 by Len Evers. This is the Guideline groups. There's a before and after trial at 4 hospitals. It's a pharmacy-based program, active TDM. They have the luxury of a 24-hour service with pharmacists on the phone, giving dose advice. So they measure gentamicin serum concentration with fluorescence, polarization, amino acids. In terms of the dosing, the initial dose was derived by a regional-specific population model to calculate the initial regime. And pharmacists, based on what they got from the results, they adjust the model with Bayesian fitting procedure and to generate their dose recommendation. So there were more than 200 patients were involved. Approximately half of them have active 24 hours TDM service. In terms of the infections, predominantly they have pneumonia, sepsis, or intra-abdominal infection, including cholangitis or cholecystitis. So that's the outcome table that briefly saw it this morning, which I'm going to go into a bit more detail. On the left-hand side is the more from Kinetics outcome. That this is the peak level on the two most left column, and this is the trough level. So with comparing TDM and non-guided TDM and with a sophisticated pharmacy guided with the backup of a dosing software, active TDM, we can see a significant increase in the peak. So we got a big exposure, but we have a significant lower trough level as well. So that's what we want really, with increased exposure and limited toxicity. And that reflects in the clinical side of things in terms of clinical outcome. They show a significant reduction in terms of length of stay, days that they use aminoglycoside therapy, and a significant reduction in nephrotoxicity. In terms of mortality, when they analyzed everybody, they didn't show any significant difference. There was a trend, but when they did a subgroup analysis, they're looking just as a patient who initially admission was a gram-negative infection. They did show a mortality benefit with an active TDM. So cost, that's the important thing to look at, which this paper has nicely done some of the cost analysis. As I said, this old paper is in the 1990s, it's still before the Euro time. So the Dutch gliders, they reported $1 approximately for 2 Dutch gliders. So you can kind of get in your head around how much that actually means in that time. The initial analysis for everybody, they have shown a significant reduction in costs for ATM, specifically the reduction in costs coming from reduced in ICU days. And when they break it down to more smaller groups of subgroup analysis, looking at the patient who initially came in with gram-negative infection, the same as the others, the cost has reduced, was mostly coming from a reduction in the cost from the board. So it's quite interesting, but overall we can see a significant reduction of costs involved, even though we're spending some money on the TDM, but relatively we're saving money from other aspects. So this is probably the most nicely done outcome cost analysis in terms of TDM intervention. Sorry, I cut this off, but basically the upper panel is, this is for all the patients to look at, is like cost effective in terms of using TDMs to improve survival, and this one, the bottom panel, is length of stay. And on the left-hand side, these two panels are for all the patients that they studied, and these are on the right-hand side for the patient that who initially came in with a gram-negative bacterial infection. So as you can see, no matter how you divided the data, you can still see a favorable effect in terms of TDM, active TDM is effective and overall less costly because we are saving money from other expenses. And there are other similar analysis in terms of aminoglycosides. These two studies are done in the United States. Similarly, they divided to this group just TDM, but it didn't do anything with the level, you just watch it. And the other column is 100%. They were actively adjusting the doses. And similarly, as the other study I showed before, it got a significant reduction in the hospital stay, length of antibiotic use. And in terms of the total cost, you can see a significant reduction. That's it. This is in US dollar. You can see it's almost, when you don't have the TDM, it's 3 times the cost of the group who have active TDM. So that's quite significant, and you can just to remember this number are in the in the 1990s, so you can translate in terms of, you know, what that means in today's day and time is probably significantly high as well. And same for the studies done in the United States as well. I think it's a moderate size military hospital. They calculate for each patient, the cost is $700 something less, but adding up everything together, they still save quite a significant amount of money. So that's the data for aminoglycosides. And let's go to vancomycin, which I think most of us are familiar with as well, but probably less data available. The most significant one is this paper in the 1996 that looked at the cost effectiveness of vancomycin monitoring. And specifically in the hematological, in patients with hematological malignancies. So they have a group of 70 patients. This is a prospective randomized study. They start vancomycin when the patient has persistent fever despite empiric treatment of ceftazidime plus amikacin or a strong suspicion of gram-positive organism infection. And these are the targets that they're aiming for 2 hours after that's the peak and the minimum trough. So what this group have shown is, sorry, just to get this out of the way. Yeah. So they didn't manage to show any difference in terms of hospital stay or length of treatment when they introduced TDM, but there was a quite strong association between TDM with reduction in nephrotoxicity, and they further broke these groups of patients down between the ones with and without nephrotoxicity, and they compare the costs associated with that. And eventually they end up that the calculation of how much is spent and how much reduction in nephrotoxicity, they end up with an increment cost of $435 per case of nephrotoxicity that they prevented. So this is the number that they look at for the mild nephrotoxicity, and for the ones that with severe toxicity is approximately equal to more than $1,000 to prevent each case. So from their point of view, they still think it's cost effective. Obviously, kidney function is important. We probably will try as much as we can to prevent that happen, and spending $300 to $1,000 probably is not as expensive, and in the calculation they haven't taken into account of the cost of associated with the nephrotoxicity as well. So the benefit is probably significantly outweigh the cost. And this further shown in this meta-analysis is done more recently, which is quite nicely done. It's published in PLOS1. Unfortunately, we only have one randomized trial, which we talk about for TDM in Vancomycin, but following a number of years, there are quite a number of core studies, especially in Japan. They pull all the data together with one RCT and a couple of others cohort study, and it's clear in terms of clinical efficacy that clearly favors TDM, and there's a odds ratio of 2.6 improvement in terms of improving clinical efficacy when the TDM is used in vancomycin dosing. Similarly, nephrotoxicity is quite clear. That was shown in the RCT, that was shown in other cohort study. And when they pull everything together, significantly favors TDM with odds ratio reduction in nephrotoxicity of 0.25. So this is quite compelling kind of data that, encourage us to do that. Unfortunately, not many studies have talked about the cost, but as you can see from one of the analysis, the cost associated with the TDM is not huge, and the cost that we save from, preventing nephrotoxicity is already quite significant. So let's talk about beta-lactam. Is one of my research area. We just touched base a little bit on that, although, as you know, the clinical outcome data is still quite limited, but one of our colleagues in Europe, Andy, this is one of these study who's a randomized controlled trial using TDM to optimize Pubmed and meropenem. Small number of patients of 41 that break down into two groups. Of one is active TDM and one is control. No standard care, no other intervention. I think 2/3 of them have Pubmed and the other third have meropenem. And when they started in the beginning, day one, similar to other data that we can see approximately 60% reached 100% above MIC and a lot less for if we target high target of 4 times above MIC. And you can see it's significant. Sorry, this bar have covered the p-value, but the p-value is definitely less than 0.07 in terms of significantly more patients have achieved 100% above MIC on day 3 when they have intervention, the TDM intervention, and similarly, aiming for a higher target of 40%, we can still get 60% of the patient getting those targets, which is quite good compared to only 10%. So, from the concept point of view, TDM can help us to achieve improve achievement of PKPD targets. I'm aware that quite a number of RCT that is either planned or in place. The target study is a prospective randomized trial that will look at TDM in optimization of Pubmed. So very exciting. And this one, the Dolphin trial, is I think it's in Netherlands and one of the European countries as well. They look at TDM in beta-lactam more broadly and fluoroquinolone. So watch this space. I don't know how COVID will affect the progress of the trial, but hopefully we'll get some more data and results in the next few years for beta-lactams. So let's move on from antibacterial to antifungal, which I found this one quite interesting. I know Hafiz have talked about this a little bit earlier in the morning, but I think I'll go into a little more detail in terms of trials that support current recommendation of doing variconsal TDM. So this is one of those a Korean trial. They look at the effect of TDM on safety and efficacy of variconsal in invasive fungal infection. It's a randomized controlled trial, nicely done in 2002. So it's a randomized, assessor-blinded, controlled, single-center trial. 110 patients was involved, and the target range is 1 to 5.5 milligram per liter on day 4. So this is quite aligned with the current guideline at the moment. In terms of the patients group, majority of them have, sorry, this column should be in TDM, no TDM in total. Majority of them have lung infection, the site infection is lung with Aspergillus, fungal infection and other fungus as well. They have successfully demonstrated that significant increase in treatment success, which include complete response or partial response for patients with active TDM. And in terms of preventing toxicity, although they didn't reach significance in terms of preventing severe adverse event, but you can kind of see is there's a trend of splitting in the chart, and the more importantly is less patient discontinue in the active TDM group, so that was a definite split in the curve and show significance. So there's, data supporting in terms of clinical outcome and prevention of the discontinuation, which I think that's very important in terms of clinical practice. So I find the meta-analysis on the utility of ferrocolloids or TDM is very nicely done. Analysis that pulling quite a number of study, and the number of RCT out there is unfortunately quite limited. But when we get every single trial we can find, we call it trial we can find, the outcome is still quite substantial. So I think there's 26 or more or less study including this meta-analysis. Some of them just look at efficacy, some look at toxicity, and some look at both of them. And in terms of successful outcome for using ferrocolloids or TDM, there is a significant, obvious, favorable trend in terms of for patients with reaching a level of trough level of more than 1, they have a definite increase in odds of clinical success. Similarly, I didn't show on this table because we're probably running out of time. They also gathered in terms of toxicity, there is a significant odd ratios of more than 4 if you have reached a trough level of about 6. So if you're interested, go and have a look at this paper. It's very nicely done meta-analysis that support ferrocolloids or clinical application of ferrocolloids or TDM in terms of improving clinical outcome, specifically for efficacy and prevention of toxicity. And you probably realize that I haven't talked about the cost because unfortunately none of those studies have did those analysis, so which is something that we need to work on in the future. And this is definitely in line with the current guidelines. So this is the British Society of Medical Mycology. They have recommended several numbers years ago already, but they still have recommended ferrocolloids. In terms of TDM, there's a high quality evidence in terms of supporting TDM to improve treatment efficacy and reduction of toxicity, and the recommendation is strong. For the other azoles and other groups of antifungals, I haven't touched on that, but you can have a look at the guidelines if you're interested. And they have breakdown quite a number of different studies and different recommendations that would be helpful in the clinical practice. So conclusion I have so far is, unfortunately, from the limited time, I can't cover every single study, but you can see there's some evidence of cost effectiveness in TDM, especially for aminoglycosides and glycopeptides. Not entirely sure for beta-lactam and antifungal. There are obviously clinical data support in terms of improving clinical efficacy and preventing toxicity. We need more data on the on the cost effectiveness on that. and hopefully there's something that leads everybody to think about, to work on, and hopefully we'll get more data in the future. So thank you very much for asking me to talk. And this one is the other guideline that Hafiz have talked about a bit earlier, that the groups get referred to. And thank you for everyone, and thank you for my two mentors especially.
Okay, thank you very much, Gloria. Now, in the interest of time, I'm just going to pop forward and stop sharing my screen. So next we have Professor Alphenar to talk to us about the study design considerations to quantify the clinical value of TDM. Hi, Jan Willem.
Hello, good afternoon.
Hi. Jan Willem is the Chair of Clinical Pharmacy at the University of Sydney. His research interests include investigating the use of anti-tuberculosis drugs, as well as the clinical application of therapeutic drug monitoring. So if you're happy, Jan Willem, I'll pass to you.
I'll share my screen. Everybody see my screen, correct?
Yes, thank you.
Great. Thank you for the kind introduction and the invitation to talk today about study design for therapeutic drug monitoring. So a little bit of an overview. Of course, we're going to talk about PK and PD. More important is what should you know before you start designing a study. Important parameters of the study, of course, are drug exposure and pathogen susceptibility. And of course, defining the endpoint for your trial. So we all know treatment of an infectious disease includes different aspects. We're looking at clinical signs and symptoms of a patient. We do imaging, do lab tests, collect blood cultures or cultures from site of infection. And based on that, we will decide which drug to select and how to administer, either as oral capsules or injection or infusion.
Excuse me, sorry to interrupt. We just think the audience might be having a little trouble hearing. So, sorry, would just be a moment.
Can you hear me, Susie?
I can hear you, yes.
Okay.
Yeah, David Grolman, are you there? Are you able to hear?
Yeah, I can hear perfectly well. Sorry, just had to unmute.
No, that's no problem. Okay, so we'll continue.
Okay, great. Thanks.
Thank
you. So if we've done all our evaluation of clinical signs and symptoms and diagnostic testing and selection of the drug, we of course hope that we will have a happy patient and a happy family at the end. But of course, we know that life is a little bit different. We have pharmacokinetic variability. Pathogens may have different susceptibility. And of course, the underlying condition may affect outcome, especially in, for example, immunocompromised patients. So we have to deal with underdosing and with a risk of emergence of resistance, clinical failure, perhaps mortality. And of course, when we look at overdosing, and we talk about toxicity, potentially resulting in premature cessation of therapy. So when we talk about therapeutic drug monitoring, it's not only measuring the concentration as mentioned in one of the earlier talks, but actually doing something with that concentration in the interest of that individual patient. And then, of course, we need that evidence to support therapeutic drug monitoring to convince everybody to actually use this methodology to optimize treatment in individual patients. So when we talk about evidence, we talk about survival, clinical cure, and of course we talk about health and economic endpoints, because if we can earlier discharge patients, that's not only pleasant for patient and family, but also for hospital associated costs. So first, of course, we start with interpreting the PKPD of that particular drug. And of course, we have a range of in vitro and in vivo studies showing nice correlations between drug exposure, antimicrobial kill or antifungal kill, susceptibility and concentration. So you have these nice graphs, and in many situations for the drugs, we have AUC over MIC, time above MRC, or peak above MRC, and one clearly stands out from the crowd, and there's often the second one who is close correlation but not as good as the first one. But then it becomes more difficult because we have to look at what the location of this infection is. Because in vitro systems, we deal with one compartment, and a little bit more advanced systems, we talk about intracellular models. But in a patient, for example, with a pulmonary infection, we talk about effective antimicrobial concentrations in the epithelial lining fluid. And of course, we have to translate plasma concentrations into epithelial lining fluid concentrations. Of course, for TDM, sampling of ELF is not the easiest way to do. In some situations, we may use bronchoalveolar lavage to get estimation of some sort of concentration at the site of infections. But this is generally not available. So we need to take into account what concentration can we expect of the site of infection. And of course, we have seen today many trials on therapeutic drug monitoring. But if we just look at what's out there on Pubmed and we search for TDM studies, often these are single center studies. That's easy